Hi, everyone. Thank you for joining me today for this talk. My name is Deborah Fazoli, and I will be talking about the life-improving benefits of outpatient palliative care and supportive oncology. I'm an assistant professor in the Brookdale Department of Geriatrics and Palliative Medicine, and I'm the medical director for our ambulatory palliative care services. I have no disclosures to report. The learning objectives for the session will be to first describe how outpatient palliative care helps to improve the lives of patients and families with serious illness, to consider the available models and guidelines for palliative care delivery as part of cancer care, and to review some of the core principles of palliative care for patients with cancer. Let's start with some simple definitions of the terms that I'll be using throughout this talk. Palliative care aims to improve the quality of life for patients and families living with serious illness. Supportive oncology, in particular, is outpatient palliative care for patients with cancer and their loved ones. This is a rebranding of the name to lessen some of the misconceptions that folks might have and to promote uptake of palliative care by both patients and providers. Let me introduce you to Mr. A, whose journey I will share throughout the remainder of the talk. He's a 45-year-old father and husband with metastatic colon cancer undergoing treatment. He's been on multiple different lines of therapy and is often affected by nausea, anxiety, and constipation related to both cancer and active treatment. Wife is his primary caregiver, and they have 2 young children. He's referred to supportive oncology by his cancer doctor for assistance with symptom management. It's always helpful to review and emphasize what we do in palliative care. And ultimately, it's really specialized medical care for people with serious illness with the goal of improving quality of life. The care is focused on providing relief from symptoms and the stresses that come with having a serious illness, and it's support that's intended for both patients as well as families and caregivers. Palliative care is appropriate for patients of any age and at any stage of a serious illness, and it can be provided together with curative or with disease-directed treatment. This is a really helpful graphic from the Center to Advance Palliative Care, or CAPC, that just sort of highlights how palliative care can be delivered concurrently with disease-directed treatment. So if we're looking at the x-axis of time, and then the amount of care that is required, you can see that palliative care here in the dark blue can really start at the time of diagnosis of a serious illness and continue throughout the patient's journey with that illness. There are times when it'll be more helpful and times when they won't need it as much, but it is really concurrent with any other disease-directed therapies like cancer treatment that they're receiving, and can continue until patient either reaches the end of life or they are in remission from whatever serious illness and no longer need palliative care services. Since its inception in the late 1960s with hospice care in England, palliative care has evolved and grown tremendously. In the United States, inpatient palliative care has set the foundation for our specialty, but in the last 10 years or so, the next phase of development has been the rapid expansion of outpatient palliative care, which is rising to meet the needs of patients with serious illness who are living longer and benefiting from this type of care. We're seeing more and more of these outpatient or office-based palliative care practices across the country, and they vary pretty widely in their structures. In general, the components of an outpatient visit are numerous, and while not all of these things might be addressed at each visit, over time, we'll likely touch on all of these different domains, including assessment and management of physical symptoms, assessment and management of psychosocial needs, as well as coping, evaluating illness understanding, providing a safe place for patients and families to ask questions about their disease course and their treatments, building relationships over time, eliciting values and goals and matching them to their treatment preferences, and assisting with care coordination and connecting patients and families with any necessary or available resources. There's often in-person and telehealth options that are available, which has made access more readily available for patients. And in general, visits for palliative care tend to be longer compared to most other specialties. New patient visits can be up to 60 minutes and follow-ups of 30 minutes, which is far more than they often get with their oncologists or their primary outpatient providers. Serious illness is not so clearly defined in the literature and is often easier to determine in the inpatient setting where there is high medical acuity. There's a consensus definition that I've included here that comes from Amy Kelly's work, which was published in 2018, and helps to frame the rest of the conversation and future research into how to best identify patients who are eligible for outpatient palliative care. This definition says that serious illness is a health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life or excessively strains their caregivers. So you really need to have both aspects of it in order for it to sort of qualify as a serious illness. With this definition in mind, an estimated 18% of the US population would meet this criteria by having a serious chronic condition, functional dependency, and also not being hospice eligible nor presently hospitalized at any given point in time. And so it's really a large percentage of people who might benefit from outpatient palliative care. We don't have a gold standard for identifying the need on a population basis, and it can be difficult to try to extract some of this data from insurance claims or electronic health records. While diagnoses are often easier to pull as data, how something impacts someone's function or quality of life, or how it impacts their caregivers is not often documented and is really difficult to extract. Nonetheless, I think it's helpful to consider how we might think about identifying the target population. Amy Kelly's work again provides some guidance on how to do this on a population level. This is helpful if you are someone who's at an institution that wants to either start or expand your outpatient palliative care services, and also if you're an individual provider who might not be thinking about a population as a whole, but about your panel of patients, helping you come up with some criteria and ways that you can identify those who would benefit from palliative care. So these are all of the different considerations. The first is just diagnoses. So thinking about what are sort of the severe chronic conditions that would count in terms of serious illness. The Dartmouth Atlas of Healthcare identifies these 9 serious chronic conditions, which are associated with 90% of all deaths. And you could extract this from diagnosis codes in the chart. So it's cancer or leukemia, pulmonary disease, renal failure, dementia, congestive heart failure, severe chronic liver disease, diabetes with end organ damage, peripheral vascular disease, and coronary artery disease. And then there's sort of a second, more complex approach of really trying to identify the severity of these conditions. So, for example, for cancer, thinking about specifically cancers with poor prognoses, metastatic or hematologic malignancies. For pulmonary disease, thinking about diseases only if patients are requiring home oxygen or are hospitalized for their condition, and then thinking about in more advanced stages of renal failure, dementia, heart failure, liver disease. And then for diabetes, thinking about those with really severe complications. Uh, and you can see that in general for those with vascular disease or coronary artery disease, uh, some other measures of functional impairment are important. Also, just multimorbidity, folks having more than 3 chronic conditions is another thing to consider. The other consideration for identifying target populations is healthcare utilization. So those who are admitted often or going to the emergency rooms often, this can be a proxy for a higher level of illness severity and potentially for care need. And then generally what they need in order to get through their day, their functional dependence, nutritional decline and nutritional needs, cognitive impairments, physical symptoms, and caregiver strains. So any patient who might have 2 or more of these is likely to benefit from palliative care. So now that we've talked a little bit about what palliative care is and which patients are likely to benefit the most, let's talk about the effectiveness and the value of outpatient palliative care in the outpatient setting specifically. This is a study or a review published in 2017 that summarized some of the publications to that date. To really try to identify what the benefit is of outpatient palliative care. So these authors identified 13 publications that had fair to good quality studies that compared palliative care interventions to usual and standard treatments for advanced and serious illnesses. So this was sort of a mix of different types of studies, many randomized control trials. Some of the studies described specialist versus generalist-led interventions, so having specialty palliative care providers versus general outpatient providers doing some of the palliative care work. 4 evaluated early palliative care interventions, and then 5 specifically looked at patient populations with cancer only. And this table summarizes some of their results. So essentially, we're looking at different outcomes that were reported in these studies. So quality of life, resource use, survival, symptom burden, patient satisfaction, psychosocial and spiritual wellness, and mood and caregiver outcomes. And then they broke it down into how many studies looked at each of these outcomes, and then stratified by those who only had specialized palliative care versus generalist palliative care, and then kind of the overall effect. And you can see that they kind of rated the strength of evidence that palliative care helps in that outcome as either no evidence, low evidence, or moderate evidence. So moderate evidence being the best here. I think a couple of things to highlight that are interesting. Quality of life, which is in the definition of palliative care, was actually only reported in 7 of the studies that they included here, although the strength of evidence is moderate, which is good in this case for there being an improvement with palliative care. Resource utilization also was reported pretty commonly and generally has moderate, although low evidence in the generalist care arm. This is important because it's one of the ways that we can sometimes make a financial argument for more uptake for palliative care. Survival is a more unexpected yet improved outcome, only reported in some of the studies. And specifically in these studies, it was looking at cancer patients, but palliative care does seem to show an improvement in survival for patients in the outpatient setting. And then you can see kind of some of the other outcomes. You can also see that caregiver outcomes, for example, and psychosocial and spiritual well-being are not so commonly measured, and perhaps because they're more difficult to measure. One thing that isn't listed here that I think it's worth highlighting, and was written in the article, is that there is a reduction in total healthcare costs in 3 studies for patients with terminal or advanced or complex illness. These authors extrapolated that if even 10% of all patients with advanced illness could enroll in palliative care programs in their last year of life, the reductions in direct medical costs could exceed $4 billion. So I think there's some interesting arguments to be made about how we could help our healthcare system as a whole. And then talking a little bit more about the survival benefit. This early palliative care can have a survival benefit, meaning helping patients to live longer. This is a really important and somewhat unexpected benefit. And this is the seminal article from 2010 that showed improved survival for patients specifically with metastatic non-small cell lung cancer if they received early palliative care as opposed to routine standard care. The reason for this is multifactorial. Part of it is likely that patients are feeling better, and so they might be able to remain on treatments longer. And there's also more discussions about goals and values and perhaps avoidance of potentially invasive interventions at the end of life that could actually cause life shortening as opposed to life prolongation. I've included some quotes throughout this talk from some of the patients in our supportive oncology practice at Mount Sinai, as I think they're illustrative of the impact that we can have. I cannot be happier with the care I receive from the supportive oncology group. To me, you are angels on earth. You are always responsive and quick to act. I am extremely grateful to have you as part of my team. So with that, let's shift gears a little bit and talk specifically about supportive oncology. So this is, again, outpatient palliative care as part of oncology. We know that the incidence of cancer is increasing worldwide, and that many patients who have advanced cancers are living longer because of more effective treatments. There's a large body of evidence that supports the integration of palliative care into oncology practice for patients who have advanced cancer. So we've talked about some of this already, but most studies showed that concurrent palliative care improves quality of life, symptom management, and also improves patient-clinician communication. Some studies show that palliative care can enhance mood, patient satisfaction, quality, end-of-life care, survival, and caregiver outcomes, and lead to an overall improvement in healthcare value. So who should be referred to supportive oncology? We've talked about who should be referred to general palliative care, but as we think about cancer care specifically, really any patient who has active cancer and who would benefit from additional support for any of the following. So active symptoms, or they're expected to develop symptoms during the course of therapy. So having palliative care involved to help manage those things as they evolve. Functional decline or multiple hospitalizations and emergency room visit. Again, palliative care can help to reduce some of this utilization, so this could be beneficial. And patients who have need for psychosocial support and assistance with medical decision making. Numerous national and international organizations all promote early palliative care involvement alongside standard oncologic care. So WHO, which is the World Health Organization, ASCO, American Society for Clinical Oncology, ACS, American Cancer Society, and IOM, or Institute of Medicine, all are consistent with their recommendations. And I'd like to spend a few minutes talking specifically about ASCO's guidelines. These were recently updated in May of 2024, it should say. This was an update to their prior guidelines from 2016. And you can see that all of the authors here really came together to review all of the available evidence and come up with some recommendations based on both the evidence as well as expert opinion on what we should do moving forward. Part of ASCO's guidelines are to also differentiate between primary and specialty palliative care, which is something that I've alluded to. And I think it's important for us to discuss now, as it helps us think about the future of our outpatient palliative care services. Specifically, primary palliative care is palliative care that is provided by oncology clinicians, whereas specialty palliative care is provided by specialty palliative care teams, so people who have received additional training and are specialists in palliative care. You can see that many of the same domains can be addressed by both primary and specialty palliative care. But as you think about what is appropriate for primary versus specialty, this can sort of help to differentiate a little bit. So for example, primary palliative care can mean assessment and management of symptoms and physical needs. Specialty palliative care can be really helpful to do those things and be an extra layer of support for patients who have advanced disease and those at the end of life, and those whose needs outweigh or outstrip what the primary providers may be able to comfortably manage. Similarly, it says assessment and management of psychosocial and spiritual concern is a part of primary palliative care. I think that's absolutely true. And specialty palliative care can step in to help manage complex physical, psychosocial, or spiritual concerns that are beyond the scope of what primary clinicians are comfortable managing. Attention to cultural aspects of care, including ethical issues, is certainly important for primary palliative care, and specialty palliative care can continue to do that. Also, communication with families and patients about goals of care and end-of-life care decisions is something that specialty palliative care really excels in. And then generally, coordination of supportive care services and referral to specialty palliative care or hospice can be successfully done by primary palliative care as well. So jumping into the guidelines specifically here, there are multiple recommendations that they made, and they framed it in the form of a research question, their recommendation, what their recommendation is based on, so the type of information that they used, the quality of the evidence that they reviewed, and ultimately the strength of their recommendation. And I have grouped them sort of in order of the ones that have the strongest recommendations, and then I'll show you the weakest recommended care plans, essentially. So the first question here is what are the most effective interventions to provide palliative care to patients with cancer, specialist palliative care services, and or generalist care by oncology clinicians. So the recommendation is that clinicians should refer patients with advanced solid tumors and hematologic malignancies to specialized interdisciplinary palliative care teams that provide inpatient and outpatient care early in the course of disease, alongside active treatment of their cancer. This is a pretty strong recommendation with moderate quality evidence to back it up. The second question is, what are the most practical models of palliative care and who should deliver palliative care? Thinking about an external consultation, internal consultation with palliative care practitioners embedded or as part of the cancer or the oncology practice, or performed by the oncologists themselves. Here they say palliative care for patients with advanced cancer should be delivered through interdisciplinary palliative care teams with consultation available in both outpatient and inpatient settings. This is a moderate strength of recommendation based on some intermediate quality evidence. Next is, how is palliative care in oncology defined or conceptualized? So kind of taking a step back and thinking about palliative care as a whole. Palliative care with advanced cancer should receive palliative care, or patients with advanced cancer should receive palliative care services, which may include a referral to a palliative care provider. And essential components include all of these different domains, many of which we've discussed together already. Rapport and relationship building with patient and family caregivers, symptom distress and functional status management, exploration of understanding and education about illness and prognosis, clarification of treatment goals, assessment and support of coping and spiritual needs, assistance with medical decision-making, coordination with other providers, and provision of referrals to other care providers is indicated. This is a moderate strength recommendation, also based on intermediate quality evidence. And now moving on to the research questions and recommendations that are fairly weak in their strength. How can palliative care services relate in practice to other existing or emerging supportive care services? So things like nurse navigation, lay navigation, community and home health care, geriatric oncology, psycho-oncology, pain, and telehealth services. The recommendation here says that among patients with cancer with unaddressed physical, psychosocial, or spiritual distress, cancer care programs should provide dedicated specialist palliative care services to complement these existing or emerging supportive care interventions. This is a weak strength recommendation based on low quality evidence. Which interventions are helpful for family caregivers, care partners, and communities? Clinicians from across the interdisciplinary cancer care team can refer caregivers, including family, chosen family, and friends of patients with cancer, to palliative care teams for additional support. Also, a weak strength recommendation based on low quality evidence. Which patients should be offered or referred to palliative care services and when in their disease trajectory? Are there triggers that should be used to prompt specialty palliative care referrals? For patients with advanced cancer, the expert panel recommends early specialist palliative care involvement, especially for patients with uncontrolled symptoms and or quality of life concerns. This is also a weak recommendation with low quality evidence, and you can see for all of these, it's an informal consensus. And what are strategies for integration of palliative care and the care of patients with hematologic malignancies in particular? And the recommendation here just says clinicians should refer patients with hematologic malignancies to specialist palliative care. This is another weak recommendation, although moderate level evidence here. And lastly, what is the role of palliative care for patients with cancer participating in early phase cancer clinical trials? Clinicians caring for patients in early phase clinical trials, including phase 1 trials, may refer patients to specialist palliative care to assess and address the needs of patients with advanced solid tumors. Weak recommendation with low evidence. So you can see that for many of these, we just don't have a lot of evidence to guide us. And generally, the consensus recommendation is to go ahead and refer patients to this ideal team of multidisciplinary providers. But I think sometimes it can be difficult to know how to translate these sorts of broad, sweeping guidelines into sustainable clinical practice. So before we move on to the next step, as we think about a little bit about the future and how we might implement some of these recommendations and guidelines practically into our institutions, let's go back to Mr. A. He establishes care with supportive oncology, and his medications are adjusted over monthly visits as well as needed phone calls to manage nausea, constipation, and cancer-related pain. When symptoms are better controlled, he shares hope of continuing to take trips with his family. They love to go to the beach in the summer. He tries to stay physically active to help cope, though is no longer able to work. He's open to reviewing support group resources in the community and finds a lot of benefit from using as needed anxiety medications prior to treatment, which the team has been prescribing for him. Supportive Oncology also provides support to his wife, communicating often by electronic messaging. They connect them both with the social worker and with child life services. And over time, Mr. A and wife share awareness that his cancer is not curable. They've not heard a prognosis and prefer to take things a week at a time for now. And he shares that he wants to live as long as possible and to spend meaningful time with his family. So we've talked about now the sweeping recommendations about utilization of palliative care as part of cancer care, but what is the optimal intervention in oncology? I think as we reflect on these guidelines and think about how to move forward, it's really helpful to think about the highest yield intervention that we can have for these patients. This is a great article published in 2018 that further defines the optimal intervention. And so these are the three features of the intervention that are most important to consider. One is that it's team-based, one is that it's timely and preventative, and one is that it's providing targeted care. So team-based is sort of shown, illustrated in this diagram. If you consider the cancer patient at the center of it all, they have all of these different domains that are impacted by their cancer: physical, emotional, social, spiritual, and informational. You then have their families who are kind of circling in their immediate orbits and trying to support them, and they may have their own needs. And then you have the team, the really multidisciplinary team that is helping to support that patient and that family. Physicians, psychologists, volunteers, social workers, chaplains, case manager, nurses, physiotherapists and occupational therapists and pharmacists, they're all really integral to providing the optimal palliative care for that patient. This is a lot of different team members, and certainly not every institution is going to be able to hire all these different team members. But as you're thinking about your own programs, trying to identify at least a few of them that can be incorporated as part of the team is really important, because we know that team-based care tends to have the best outcomes for patients and families. Palliative care should be timely and it should be preventative. What does this mean exactly? Well, timely palliative care refers to a variety of different aspects of care. One is timely symptom management. So thinking about when in the disease trajectory palliative care can be most helpful for managing symptoms. Certainly, we can help to maximize cancer treatments. And so some would argue that the earlier palliative care is involved, the better, in order to prevent some of these symptoms from getting worse. Having fewer symptom crises and handling the crises that occur, and really overall trying to achieve optimal symptom control. We also think about timely palliative care in order to provide longitudinal psychosocial support. We know that if we meet the patient a little bit earlier and get to know them over time, there is more opportunity to develop rapport and to develop that kind of psychosocial support over time. We could help with providing care to caregivers, decreased anxiety and depressions for patients themselves, and making sure that patients are receiving proper spiritual care. And overall, having an enhanced communication and decision making. Again, trust and relationship building is more likely to happen if the palliative care team is involved over prolonged periods of time. End of life discussions can happen more organically, and cancer treatment decisions at the end of life can also be supported with the palliative care team's input. All of these different domains can ultimately help to improve patient outcomes, as we've seen when we've reviewed the data. Improved quality of life and symptom control, greater satisfaction with the care that they're receiving, less aggressive care, and potentially prolonged survival as well. And then thinking about targeted care. So while we want our care to be team-based and timely, meaning early, we also wanted to really target the patients who need it the most. And so this schematic outlines what we really mean by targeted. So in example A here, if you have a universal referral, so let's say everyone in this practice, as long as they have cancer, gets referred, you'll see that in the top row, all the little stick figures in blue have severe distress and unmet supportive care needs, so they need a referral. And all the stick figures in orange have their needs adequately addressed by the oncologist, so they don't have as much of a need for palliative care. If you refer all of these patients to palliative care or supportive oncology, you're likely to have improved outcomes for many patients, but you might overwhelm what is a limited resource, and some patients might not need palliative care yet. And so it might be an unnecessary visit for them. While that might not seem like a big downside, many of these patients have significant appointment burdens and are not able to work or do other things because they're so busy with clinical visits and treatments. And so trying to reduce the number of appointments can have a real value for them. In schematic B, it's a selective referral. This is what happens in most practices. Really, it's at the discretion of the provider to refer a particular patient to palliative care, or sometimes a self-referral. In this model of care, you'll capture some of the people in blue who truly need palliative care, but you'll miss some of those who need it, and you might end up referring some who don't really have a huge need for it. So again, you might be using the resource without necessarily needing to. Ideally, we would have schematic C, in which there is some sort of systematic screening that identifies all of the patients who might benefit. And then there's also needs-based referral that gets coupled with it. So you can imagine a report is generated that says these are all the patients in this practice who meet some sort of predetermined criteria. And then a provider would review them to say these patients are adequately controlled. These other patients I do think need it, and I'll refer them. This is a way to ideally try to match the resources to the care needs of that group of patients. There's really, I think, considerations for outpatient palliative care as a limited resource. Again, while we would want to provide care to all the patients who could potentially benefit, the reality is that we don't have unlimited numbers of palliative care providers and teams. And so it is helpful to think about how do we move forward providing this care with the limited resources that exist. Uh, Primary palliative care education and support is really a big part of this. We want oncologists and every team member of the oncology team to feel comfortable doing some amount of primary palliative care education to tackle all of the different domains that we know are helpful in improving outcomes. And so this can be education that happens certainly at the graduate medical education level, in medical school, in residency fellowship, and also while people are working. I think there's a lot of opportunities for doing CME, just like this one, to become more comfortable with these types of trainings and skills. There's also many innovative models of care delivery. While the ideal intervention would be sort of team-based and multidisciplinary, there's multiple models that exist nationwide, and we don't have a lot of data on what is most effective, apart from knowing that a team tends to be best. And so you could consider freestanding clinics, so palliative care clinics that exist on their own and patients go to them. You could consider embedded clinics. So supportive oncology often is an embedded practice in a cancer center. There's also other types of embedded palliative care clinics in heart disease and others. And then considering single disciplinary palliative care and nurse-led practices. So Having, for example, a nurse practitioner who is the sole provider in a particular practice, having nurses be the drivers for palliative care at a particular site, and only referring out to a multidisciplinary team if there's a lot of complex needs. So there's ways that you can kind of provide this care without having the full-fledged team be a part of it. Also, we're trying to think about reserving the specialty palliative care for those who need it most. So this is where the targeted aspect of the care comes in, is really trying to provide as much primary palliative care as you can, and then really reserving the multidisciplinary team for those who need it the most. And telehealth is something that has improved access to palliative care tremendously and is likely to continue to do so. There's some literature that shows that this is effective and patients really like it and want to continue to use it. And so I think creatively about ways in which telehealth can be used to ensure there's adequate palliative care access for all patients who need it. We do need continued research to determine the most high yield interventions in this population, as we're not sure exactly which dose, if you will, is the best for palliative care to have its desired impact. And I think there's a lot of room for ongoing literature in this world. This is another quote. On Sunday morning at 2:02 a.m., our dear mom transitioned into the metaphysical realm. As you know, she had endured a very brave and long-term struggle with her cancer over the last 5 years. One of her last wishes was that we convey how much your unending support had buoyed her spirits in times of need. Your counsel and genuine caring left a lasting impression on mom. It made her feel like she could overcome any and all obstacles. For the last section of this talk, I want to review the core principles of palliative care for patients with cancer. Each of these domains warrants its own talk, which you can seek out as part of the CME. I primarily want to give a quick framework for how we approach each area clinically in our practice, so that you might consider implementing some of these principles in your own institutions as part of primary palliative care. So starting with symptom control, this is certainly something that we do a lot of, and we often focus on what is most bothersome to the patient at an initial visit as well as subsequent visit, and it often does change over time. We're also screening patients often at their initial visit to try to identify which symptoms we can help with. The ESAS, or the Edmonton Symptom Assessment System, is a common tool that's used to try to better understand how bothersome symptoms are. It can also be used to track how these symptoms evolve over time. And then we try to manage the symptoms as best we can. As part of management, it's always really important to think about the etiology. It's while we are palliative care clinicians, we also all have training in something else. And so thinking about the differential diagnoses and what diagnostic tests you might want to recommend to their referring providers can be an important part of helping to manage that symptom for that patient. We always try to think about non-pharmacologic ways to help them manage, and sometimes there are no pharmacologic tools that are available for managing a certain symptom. So this is especially important, and often getting creative in the absence of much data to manage some of these symptoms. And then thinking about pharmacologic means in managing symptoms. Certainly, I think this is most relevant when we're talking about pain and the use of opioids. It is really important for any practice who is using opioids routinely to manage cancer-related pain to think about doing it in a way that is safe and equitable, and really making sure that the opioid prescribing practices are consistent. Um, we do our best to prescribe in this way, and it means that we screen for substance use and risk factors for opioid use disorder for all of our patients who are getting started on opioid therapy, providing consistent education about side effects and harm reduction strategies, prescribing the lowest effective doses, and then titrating with care, assisting with medication access when possible, given the numerous barriers that our patients are facing in communities nationwide to be able to access their medications, scheduling regular follow-up and having clear boundaries for situations in which we might not prescribe, and being thoughtful about tapering opioids and transferring of prescribing when it's clinically indicated. Oftentimes, we'll see patients who have cancer and come to us with non-cancer chronic pain. And unless their prognosis is quite short, if we think that patient is likely to live for many years, we often will not take over managing that particular chronic pain syndrome. And so really being thoughtful about uh, what you're managing. And making sure that regardless of the symptom that you have frequent follow-up. This is one of the reasons why it's important we maintain access, because we know that if we're seeing patients more often, whether it's in person, doing telephone calls or virtual visits, that frequent contact is often what helps to really adequately control their symptoms. Thinking about psychosocial support and coping. And so really exploring and screening at visits how they're doing on this difficult journey. These are some types of questions that we often ask. How are you handling all of these challenges? Who is supporting you on this journey? What gives you strength when you have a difficult day? I think these can all be questions to help discover what a patient is going through and support them in figuring out ways to cope. There is a therapeutic benefit to the visits, and while we're not often doing formal counseling or therapy, I think the amount of time that we spend with patients is in talking about these things is more than they get with any other provider, and that can have a real benefit for them. And then making sure that you connect patients with any relevant resources and team members. So kind of knowing what's available in your communities, in your health centers, and making sure that you connect them with social workers, chaplains, and any other team member who could be helpful. And pharmacotherapy, we do have comfort in managing primary depression, anxiety, adjustment disorder, kind of being familiar with the use of SSRIs and SNRIs, benzodiazepines, atypical antidepressants. These are all medications that we use fairly commonly. Thinking about advanced care planning. And so in the outpatient setting, it looks a little bit different than when someone is inpatient. It often means discussing the surrogate decision makers, helping to fill out a healthcare proxy, and if not, making sure that we know who the surrogate decision maker is and documenting it in the chart. Understanding their illness understanding over time. And so some questions that you might ask are, what have the doctors shared with you about your cancer and what to expect in the future? Something very open-ended can lead to really important information being shared during the visit. What have they told you is the goal of the treatment? And then also assessing their information sharing preferences. How do you prefer to hear important medical updates? Do they like to be alone, or do they like to have family members with them when they're hearing important updates? Making sure that they know that they can call their loved ones if they're receiving news unexpectedly, to make sure that they can advocate for themselves. Understanding if they like to hear details or if they prefer big picture updates as well. And then doing future planning and exploration of goals and values. What worries you and what are you most hopeful for? What are some important goals of yours that we should know about? And framing it in the context of wanting to help them achieve their goals. I think these are all questions that can really help to get that conversation going. And ultimately supporting them with treatment decisions. There often have to be treatment decisions that are made at various points on a journey with cancer, and being able to support them at each point can have a lot of value. And lastly, care coordination, making sure that we're communicating with the oncology team, kind of sharing our feedback, our observations, our recommendations, advocating for patients and families if we're noticing anything that is falling through the cracks, and helping to make sure that their needs are being met in the best way possible. Collaborating with other providers. Many patients will have non-oncology providers as well who are involved in their care, so making sure that we're communicating with everyone. And helping with transitions across care settings. Our patients might go from outpatient to inpatient to nursing facilities. They might also get their care at different healthcare institutions. And so making sure that things are as smooth as possible across all of these care transitions. So going back to Mr. A, 2 years after establishing care with supportive oncology, his progressive weight loss and weakness and is found to have disease progression. No further cancer treatments are recommended at this time. The supportive oncology team joins one of the oncology visits when this news is shared, and has additional appointments with patient and wife to talk about what this means and discuss prognosis of weeks to months. He's not ready to talk about next steps yet, and a few days later decides to go to the hospital for worsening pain and nausea that are difficult to manage at home. He's seen by the inpatient palliative care team, who has been communicating with supportive oncology. When symptoms are better managed, patient and wife made the decision to focus on comfort care. He's eventually discharged home a week later with home hospice. I think his case illustrates the longitudinal way in which supportive oncology can really be involved in helping a patient and their family, and can also help with some of the transitions of care that often do happen for patients who have cancer. So, looking to the future of supportive oncology, continued education for providers and patients about the benefits of palliative care is really important. And continuing education for primary palliative care for oncology teams is going to be key to expansion of service. We want to continue to integrate specialty palliative care with these targeted and timely referrals, and to do that, we need to improve the palliative care workforce shortage, hopefully have more funding for palliative care training, and also have a healthcare system support for supportive oncology clinic infrastructure. And so thinking about ways that we can advocate for funding to have these palliative care services be part of cancer care, thinking about value-based care models and how you make the case for how palliative care can help to save money and improve patient outcomes. And with that, I'd like to summarize the take-home points. Outpatient palliative care can help improve the lives of patients and families with serious illness across many domains, including symptom management, mood, and coping, and improve the value of healthcare. Different models of supportive oncology might be appropriate depending on the setting you're in, available resources, and volume of patients. But palliative care delivery that is team-based, timely, targeted is likely to be the most effective. The general principles of palliative care can be incorporated into routine oncologic care. So I hope that what we've talked about today resonates with many of you and can be utilized in your practices moving forward. Thank you so much for your attention. These are some useful resources, and this is my contact should you have any questions or comments. Thank you.